Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, I am going to discuss one more topic in scrotal swelling, that too the 10 MCQs I am going to discuss. So today's topic is Torsion Testis. You all know the importance of the MCQ because nowadays MCQs are used worldwide both in the qualifying as well as in the competitive medical entrance exams. Like the qualifying exams are MS, MBBS, MS, MD, all those things are, or even MB, BCH. All these things are qualifying exam. And the competitive medical entrance exams are the NEET PG, NEET SS, or the FMG exam in India, and the USMLE, UKMLA, and AMC, that is Australian Medical Council entrance exam. All these exams are using only MCQs as a testing method or the assessment method. So I need not tell about the importance of MCQs nowadays. So these series of videos which I am doing nowadays will give you a systematic way of revising the whole spectrum of general surgery, topic by topic. I will be revising it. So before going to discuss the 10 MCQs regarding the torsion testis, I want you to watch that particular video on torsion testis. This is my video in my YouTube channel, and all the 10 MCQs which I am going to discuss are based on this video only. So kindly pause this video and click the below link and watch and learn everything in that particular video. After watching the video and learn the content thoroughly, now, okay, let us discuss the MCQs one by one. So after the last video I have uploaded, that is on hydrocele scrotal swelling MCQs, some of my viewers have suggested me to upload the corresponding mind map also for them so that they can revise that particular topic very easily. See, the uniqueness of my teaching videos are three things. I've told in many of my videos, they are number one, mind map. You cannot see this kind of mind map. Maybe in no other textbook they are giving this mind map. So this is a very powerful tool to revise the topic very quickly. Torsion testis, whatever I am showing in that video, everything is there in this one page mind map. So first, for example, in testicular torsion, I will be discussing about the etiopathogenesis, what are the various types of testicular torsion, what are the symptoms, that is the history, what are the signs, that is the physical examination, and then diagnosis is by investigation. What are the investigations you have to do, and then treatment. Sometimes I may even discuss post-op complication, and if it is a tumor case, then the follow-up also, the prognosis and follow-up is also very important. So hereafter I will be sharing this mind map in all my these MCQ videos. So coming to MCQ number 1, a 15-year-old boy presents with sudden onset of severe right scrotal pain and nausea for 3 hours. On examination, right testis is higher than the left and there is an absence of cremasteric reflex. What is the most likely diagnosis? A. Epididymoarthritis. B. Testicular torsion. C. Hydrocele. D. Inguinal hernia. Of course, the correct answer is testicular torsion because of the classical history. Sudden onset of pain, acute pain. High riding testis. The testis on the affected side is lying in a higher, area. And the absent cremasteric reflex. All are hallmark features of a testicular torsion. So if it is epididymoarthritis, that is also acute pain, but there won't be any absent cremasteric reflex in epididymoarthritis. In testicular torsion, that is the answer. Hydrocele, this is not an acute problem. Inguinal hernia also is not a acute painful condition. So you can rule out all other things except testicular torsion. Question number 2. A 16-year-old boy present with acute scrotal pain that started 5 hours ago. He also reports nausea and vomiting. On examination, the right hemiscrotum is erythematous and the testis is tender and elevated. What is the best next step in management? A. Observation. B. Scrotal ultrasound with Doppler. C. Immediate surgical exploration. And D. Antibiotic therapy. So the correct answer is immediate surgical exploration. Observation, no, that is not correct. Because you should not, this is an acute problem, you have to intervene immediately. Scrotal ultrasound and Doppler can be done if you are seeing the patient in very early, immediately if they are coming. It's already 5 hours have gone. So you can do, this is also can be done. Duplex scan, confirm the diagnosis, and then because it could be an acute epididymoarthritis also, which you cannot differentiate clinically, whether it is acute epididymoarthritis or, so you can do scrotal ultrasound and Doppler also, but already 5 hours have elapsed. And that is why, and patient is presenting typically with all other, the elevated testis is also there, cremasteric reflex is absent. So in acute epididymoarthritis, cremasteric reflex won't be absent. So that is why the immediate surgical exploration is the correct answer. Testicular torsion is a surgical emergency and immediate detorsion is required to salvage the testis. With the best outcomes if surgery is performed within 6 hours. Almost 100% of the testis you can salvage. But if it is delayed, then only if it is 1 day after, the onset of the symptom, if you are operating, only 20% of the testis you can salvage. Okay, that is the importance. So coming to MCQ number 3, 12-year-old male present with acute left scrotal pain and swelling. Pain is not relieved by elevation of the scrotum, which is called the Prehend sign, negative Prehend sign. And there is no cremasteric reflex on the affected side. Which of the following findings would confirm the diagnosis? Presence of hydrocele. B. Blue dot sign. C. Absence of blood flow on Doppler ultrasound. D. Decreased urine output. Of course, the correct answer is C. Absence of blood flow on the Doppler ultrasound to the center of the testis. There will be blood flow to the periphery of the testis, but to the center of the testis, there shouldn't be any blood flow. That is very important. Doppler ultrasound or duplex scan showing absent blood flow in the testis confirms the diagnosis of testicular torsion. So the presence of hydrocele is not the correct answer. Blue dot sign you will see only in testicular appendages torsion, and decreased urine output is also not a sign of, the torsion testis. Coming to MCQ number 4, a 14-year-old boy comes to the ER with severe scrotal pain that started 2 hours ago. His parents mentioned that he experienced similar pain a few months ago, which resolved spontaneously. On examination, right test is very tender and lies higher than normal. What is the most likely underlying anatomical abnormality predisposing him to this condition? A. Undescended testis. B. Inguinal hernia. C. Bell clapper deformity. And D. Hydrocele. So the correct answer is bell clapper deformity. The bell clapper deformity predisposes individual to testicular torsion as the testis is not properly attached to the scrotal wall, allowing it to twist easily. So bell clapper deformity, the tunica vaginalis incision will be higher in the spermatic cord, so the spermatic cord can get twisted intravaginally, that is inside the inside the the tunica vaginalis. That's why it's called intravaginal torsion testis. It's very common in adolescents, whereas extravaginal torsion testis is very common in neonates. So coming to the MCQ, 17-year-old male present with sudden onset of severe left testicular pain and vomiting. His left testicle is elevated and there is no relief with scrotal elevation. What is the time frame in which the testicular salvage rates are highest if surgical intervention is performed? A. 2 hours, B. 6 hours, C. 12 hours, and D. 24 hours. The correct answer is B. 6 hours. Testicular salvage rates are highest if surgery is performed within 6 hours of onset of symptoms. Beyond 24 hours, the salvage rate drops to only 20%. Coming to MCQ number 6, the 20-year-old male present with sudden scrotal pain for 7 hours. On examination, left testis is extremely tender and swollen. There is no cremasteric reflex on the left side. Doppler ultrasound shows absent blood flow to the testis. What is the best course of action? A. Antibiotic therapy. B. Urgent surgical exploration and detorsion. C. Scrotal ultrasound. D. Watchful waiting. Of course, the correct answer is B. The urgent surgical exploration, and you have to detorse the testis. Urgent surgical exploration and detorsion is necessary to save the testis when there is absent blood flow, as it is confirmed by the duplex scan or Doppler ultrasound. Not only detorsion should be done, then you have to watch for uh, the blood supply to the testis. If testis is viable, yeah, after detorsion, if the color comes normal, then you have to do what is called fixation archaeopexy on the affected side. But the most important thing is that means you have to fix the testis in 3 places: the upper pole of the testis, the lower pole, and in the middle. You have to fix the tunica albuginea of the testis to the dartos muscle with non-absorbable suture material like proline. This is what you have to do. You have to do not only on the affected side, even the normal side, you have to explore. If patient is having bell clapper deformity, most of them will be having this problem. So you have to do prophylactic fixation archaeopexy even on the normal side. This is very important. Please remember this point. MCQ number 7, 14-year-old boy present with right lower quadrant pain and nausea for 6 hours. On physical examination, his right testis is swollen, tender, and position higher than the left testis. Diagnosis is testicular torsion. What would be the most appropriate next step? A. CT scan of the abdomen. B. Doppler ultrasound of the scrotum. C. Immediate scrotal exploration. D. Urine analysis. So the correct answer is immediate scrotal exploration and confirm the diagnosis of testicular torsion if duplex scan is not done yet. In a patient with suspected testicular torsion, immediate scrotal exploration is necessary to prevent ischemic injuries. So within 6 hours, if you are intervening, you can salvage 100% the testis. That is why as early as possible, you have to do it. Delaying for imaging may risk testicular necrosis. Question number MCQ number 8. Which of the following is the most common age group affected by testicular torsion? A. Infants. B. Pubertal boys. C. Adults. D. Elderly men. So the correct answer is B. Pubertal boys. Testicular torsion has got two peakings. One is neonate, another one is teenage or pubertal boys. Okay. Here in the option they haven't given neonates. They have given only infants. Neonates means within 28 hours. 28 days of birth. Infants means after 28 days up to 1 year is infant. So they haven't mentioned the neonatal babies. If neonate is put, then both are correct. Pubertal boys also correct because it has got two peakings in age. One is pubertal boys, another one is neonatal boys. So coming to MCQ number 9, which of the following is a clinical sign of testicular torsion? Prehensile sign, cremasteric reflex present, absent cremasteric reflex, and D, transillumination positive. Of course, the correct answer is C, that is absent cremasteric reflex. The absence of cremasteric reflex on the affected side is a classical finding of testicular torsion. Whereas in case of testicular appendages torsion, there won't be any, absence of cremasteric reflex, and in addition, patient also will have what is called blue dot sign. Coming to MCQ number 10, which deformity is commonly associated with testicular torsion in adolescents? A. Bell-Klopfer deformity. B. Hydrocele. C. Inguinal hernia. D. Varicocele. Correct answer is of course A. Bell-Klopfer deformity, where the testis lies horizontally and tunica vaginalis has got a high incision in the spermatic cord. So the boy will go for what is called intravaginal testicular torsion. This is common in adolescent. Whereas the extravaginal testicular torsion is very common in neonatal babies. Because in Bell-Klopfer deformity, the testis is lying horizontally, it is more mobile, which is predisposing the boy to testicular torsion. So as I told you in the last slide, of late, I've written 3 books and published them in Amazon. So one is on how to master answering MCQ. Another one is how to answer MEQs. What is MEQ? Maybe in my institution, each and every exam we are conducting MEQ also. MEQ is modified essay questions. We no longer we are asking essay questions to the students like the old age exam, where we will be in during my time when I was doing my undergraduate and postgraduate, we used to answer a lot of essay type question, but nowadays it is modified essay question. This is also case based. They will give a case scenario and slowly they will unfold the full clinical scenario, and you have to show your efficiency in clinical reasoning. And another one is, of course, ASCII exam, objective structured clinical exam. Because of getting enough clinical material is very tough nowadays. Many of the medical schools are implementing ASCII exam to assess the patient's proficiency. The students' efficiency in clinical skills. This is ASCII exam. So, if you want to buy these books, in the description, I am giving the links to all my ebooks in many Amazon schools like US Amazon store, UK Amazon store, Australian store, and Indian Amazon store. All links I have given in the description. You can go click and you can buy these books. So thank you very much for watching this video. If you think that these videos are very useful to you, kindly share it with in your social media and subscribe to this channel. You please click the bell button also to get notified regarding my latest upload. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.